Hello and welcome to the topic Mitral Regurgitation and Mitral Valve Prolapse in the Cardiology module. By the end of this session, you should be able to define mitral regurgitation and mitral valve prolapse, explain the causes and pathophysiology of mitral regurg and mitral valve prolapse, classify mitral regurgitation and mitral valve prolapse, describe the clinical features of mitral regurgitation and mitral valve prolapse, outline the principles of management of mitral regurgitation and mitral valve prolapse. Let's get started. So let's dive into what is mitral regurgitation. Mitral regurgitation occurs when blood leaks back through the mitral valve on systole. The mitral valve is located between the left atrium and ventricle, and regurgitation leads to a less efficient heart as less blood is pumped through the body with each contraction. This said, mitral regurgitation is common in otherwise healthy patients to a trivial degree and does not need treatment. As the degree of regurgitation becomes more severe, the body's oxygen demand may exceed what the heart can supply, and as a result, the myocardium can thicken over time. Whilst this may be benign initially, patients may find themselves increasingly fatigued as a thicker myometrium becomes less efficient and eventually go into an irreversible heart failure state. You can think about the causes of mitral regurgitation from the points of defects with the valve itself or the attachments of the valve, which are quadrantenninae and papillary muscles. The valve can be defective secondary to rheumatic heart disease, endocarditis, or if there is a prolapse of the mitral valve. The attachments can be defective following acute myocardial infarction, dilated cardiomyopathy, and collagen vascular diseases such as Ehlers-Danlos syndrome or Marfan syndrome. A relative mitral valve insufficiency occurs when the reason for the inability to close and can be attributed to the dilation of the mitral valve annulus. This can occur as part of dilated cardiomyopathy. In an acute myocardial infarction or mitral valve prolapse, as well as congenital heart disease, the quadrantenninae and papillary muscles can be affected. Calcifications as well as rheumatic and bacterial endocarditis may result in mitral valve insufficiency. Degenerative changes can occur as part of such conditions as Ehlers-Danlos syndrome, Marfan syndrome, or mitral valve prolapse syndrome. Now let's take a look at the 4 grades of classification of mitral regurgitation. Mitral valve insufficiency can be divided into 4 grades, just like aortic valve insufficiency, depending on their regurgitation fraction. Grade 1 is defined as regurgitation fraction of less than 20%. So there's little contrast agent entering the left atrium and it's completely excreted again in the systole. Grade 2 would be regurgitation fraction 20 to 39%. The left atrium fills up completely but is weak after several heartbeats with a contrast agent. Grade 3 is regurgitation fraction of 40 to 60%. The left atrium fills up completely with a contrast agent. The contrast medium density in the left atrium corresponds to the density in the left ventricle. And grade 4 is where the regurgitation fraction is more than 60%, where the left atrium fills up completely with a contrast again during the first or second heartbeat, and the contrast medium density is higher in the left atrium than it is in the left ventricle. Reflux of contrast agent into the pulmonary veins occur. Let's take a look at the pathophysiology of mitral regurgitation. If the mitral valve does not close properly, the blood from the left ventricle is only partially directed into the systemic circulation. The other part is pumped into the left atrium again, and since the pulmonary veins have no valves, it's pumped back into the pulmonary circulation. This leads to an accumulation of blood in the lungs and thus to pulmonary hypertension, right ventricular load, and right heart failure. Since the cardiac output would fall into the left atrium due to the return of the flow, the left ventricle must intensify its work in order to maintain it. Thus, this also causes an increased strain on the left ventricle and the left ventricular hypertrophy and dilatation occurs. Most patients with mitral regurgitation are asymptomatic, and patients suffering from mild to moderate mitral regurgitation may stay largely asymptomatic indefinitely. Symptoms tend to be due to failure of the left ventricle, arrhythmias, or pulmonary hypertension. This may present as fatigue, shortness of breath, and edema. The murmurs heard on auscultation of the chest is typically a pansystolic murmur described as blowing. It is heard best at the apex and radiating to the axilla. S1 may be quiet as a result of an incomplete closure of the valve, and severe mitral regurgitation may cause widely split S2. Signs on the ECG are dependent on the adaptation mechanisms of the heart. In pulmonary hypertension, a right axis deviation. In left ventricular hypertrophy, more of a horizontal heart can be seen. ECG may show a broad P wave indicative of atrial enlargement. The P wave may have two peaks. Cardiomegaly may be seen on chest X-ray with an enlarged left atrium and ventricle. Pulmonary venous congestion may also be identified. The valvular apparatus should be assessed using echocardiography. The degree of insufficiency can also be determined using this method. Let's get to the treatment of mitral regurgitation. Conservative treatment for mitral regurgitation includes physical rest, and if the risk of atrial fibrillation exists, prevention of thromboembolism should be initiated with anticoagulants. Decrease afterload by using ACE inhibitors or ARBs, especially if mitral regurgitation is associated with systolic dysfunction. Decrease the pulmonary congestion with diuretics and digitalis. Regular follow-ups ensure that the indication for surgery is not overlooked. So once the contractility of the ventricle is restricted, there is a danger that even a reconstruction will not be able to help produce ventricular function again. Ideally, a mitral valve repair should be carried out. This can be done in a minimally invasive or surgical way. A mitral valve replacement is possible with a mechanical as well as a biological prosthesis. In acute severe regurgitation, surgery is indicated. The evidence for repair over replacement is strong in degenerative regurgitation and is demonstrated through lower mortality and higher survival rates. When this is not possible, valve replacement with either an artificial valve or a PICC valve is considered. Next, let's have a look at what is mitral valve prolapse. The mitral valve prolapse refers to the bulging parts of the mitral valve cusp during systole in the left atrium. If symptoms occur, the disease is called mitral valve prolapse syndrome. The mitral valve prolapse can result in mitral regurgitation and considered the most common cause of isolated mitral regurgitation. The reason for mitral valve prolapse may be a disproportion in the size of the valves, the left ventricle, and the valve retaining apparatus. Connective tissue weaknesses such as Marfan syndrome or myxomatous degeneration can also be a cause. Mitral valve prolapse usually occurs as an isolated entity. It commonly occurs with heritable disorders of connective tissue including Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, and pseudoxanthoma elasticum. Mitral valve prolapse has also been described in association with a secundum atrial septal defect and hypertrophic cardiomyopathy. Only about 10% of affected individuals show symptoms. These include arrhythmias and palpitations, syncope, dyspnea, and diminished performance, as well as anxiety and atypical chest pain. Patients may complain of atypical chest pain or palpitations, mid-systolic click, which occurs later if patient is squatting, late systolic murmur, and it occurs longer in patients that are standing. Complications such as mitral regurgitation, arrhythmias including long QT syndrome, emboli, and sudden cardiac death. The ECG is often unremarkable, possibly characterized by a flattened T. If patients are asymptomatic and have no arrhythmias or mitral regurgitation, no treatment is necessary. Rechecks should be performed in 5-year intervals. Patients with higher grade mitral regurgitation should, however, observe some specific behaviors. This includes maintaining a normal weight, abstaining from nicotine, alcohol, and caffeine, as well as avoiding strenuous exercise and sports. Rechecks should be performed in 1 to 3 year intervals in these cases. Let's recap. Mitral regurgitation is the backflow of blood back through the mitral valve into the atria during systole. Mitral valve prolapse is a condition of prolapse or floppy mitral valve leading to mitral regurgitation. If you're thinking of heritable conditions such as collagen vascular diseases, look for other telltale signs to help you clinch the diagnosis. Commonly, these conditions are due to acquired diseases such as rheumatic heart disease, ischemic heart disease, and endocarditis. Best mode to diagnose if suspected from clinical examination will be an echocardiogram. It is fast and non-invasive as well as provides enough information on the type of valvular defect and severity of the defect. Treatment is largely dependent on the severity of the defect as well as presence of complications secondary to the defects such as arrhythmias or cardiac failure. We have come to the end of this topic. Thank you.